Hello class, this is Dr. Darty. I will be presenting the clinical management section for musculoskeletal 1 orthopedics class. So let's get started. So when we speak about clinical management, I think the words do a pretty good job of inferring the meaning. All right, but let's talk about the purpose. Why do you think it's important to learn how to clinically manage a patient? Well, the purpose is really to get better at managing the overall spectrum of the patient's care. So they come in, we take a history, we perform our 18 steps, we evaluate the patient, we make our prognosis, prognosis, and then we move on to the intervention. And this is really the process of clinical management and setting those appropriate goals based on what he or she wants to get back to and based on their current functional limitations and also their prior level of functioning. So let's also talk about the usefulness. I feel like that's pretty well implied as well, in that it makes sense that we need to use this because in the clinic you will be using this on a daily basis. So this is a very important subject, and this is your introduction to a subject that we are going to continue throughout this term and throughout other coursework here. Okay, what are the principles of treatment according to Salter? This is your Salter recommended textbook. Again, this is in the library, but we will be referring to this often throughout the term, so I would make sure I could easily get my hands on a copy. First and foremost, remember we're following the medical model now, and you are a specialized medical healthcare practitioner. All right, you are not a physician, but a physician is not you. You each have your specialized skill set. But we do like to emulate the medical profession in a number of ways. So primarily, do no harm. The Hippocratic Oath, right? Do no harm. Number 2 is you really need to base your treatment on an accurate diagnosis and prognosis. I know this seems kind of ridiculous, but it is amazing in the real world how often you see people that are treating with somewhat of a shotgun approach because they're really not sure what's going on with a patient. They don't really know what the diagnosis is, and so they're very vague about the prognosis, and then they really use these vague shotgun approach treatments and they don't really get the results they want. So select treatment with specific aims. So every treatment you choose, you should have an outcome in mind based on the effect of that treatment. Cooperate with the laws of nature. You have to respect the normal policies of nature. You have to respect healing. A normal time for healing. You have to respect how that healing varies with age, with systemic pathology, and also with the tissue you're talking about. I think it's somewhat straightforward to understand that different tissues in the body have different vascularity, and that something that only has peripheral vascularity, such as a meniscus, within that same tissue won't heal as well internally as it would with an external pathological injury. Same goes for more of a vascular structure, like a muscle tear is going to have different vascularity and it's going to heal at a different rate than, let's say, your average ligament will, because they tend to not be as vascular. Be realistic and practical in your treatment. Be practical in that you need to have in mind where you want to end up, and you have to take this pragmatic approach. You have to meet the patient's goals, but you got to be realistic. You can't think that overnight these changes are going to happen with every single patient. In some they will, but in others it's going to take time. So be realistic with your goal setting and with your interventions for that day. Select individual treatment for your patient. We do not teach the cookbook approach at this institution. We will introduce you to things such as clinical guidelines for managing certain conditions, but we don't advocate these cookbook general approaches. Each patient, even if they have the same diagnosis, may have somewhat different impairments, and you are learning the impairment-based model to musculoskeletal pathology, so you want to treat based on. Remember, therapy is more concerned with disability, right? More concerned with disability. The medical model is more concerned with the pathology. Now, we really take into consideration both, but just remember that overall we're more concerned with improving their functional outcome. You'll learn about certain pathological conditions in this course and in others in which we're not even sure theoretically why this patient's getting better, but we know that we can decrease their pain, improve their range of motion, and improve their functional outcome. They're happy and we're happy. It doesn't matter if upon histological studies the tissue looks the same. That's less. Concepts of clinical management now. Let's lay the groundwork here. Treatment of and beyond the specific pathological process involved. So we do not just treat the pathology. We treat beyond it. We treat more than that. We look for the cause of that pathology. We look for how that pathology will affect their functional outcome. Etiology factors means causative factors, correct? You've all had medical terminology. You know that etiology means cause. So what caused this issue? Okay, not every issue is just insidious on its own. It just innocently occurs. A lot of times musculoskeletal pathology can be caused by the stresses we are placing on that tissue, and when there's a cause for abnormal stress, we get pathology. Psychosocial implications, such as maybe it's the way the patient views medical professionals as a whole. Maybe he sees you as another medical professional wearing a white coat, and so he has white coat syndrome. So whenever you try to work with a patient, they're very nervous, maybe even agitated. Or there's other psychosocial implications, like maybe they blame the injury for the loss of their role as an athlete or as a mother or a father or a grandparent. And so there's this emotional connection to their pathology and to their impairments. And so you have to holistically view that and analyze that and incorporate that as well. Let's move on to decision-making elements for treatment selection. These are things you're going to learn about today. Tissue-specific impairments. Now, tissue-specific impairments are different from impairments. And out there in the real world, a lot of times you will be able to get by with just an impairment. An example of an impairment is very general, such as decreased range of motion, decreased strength, decreased endurance, decreased joint mobility, so on and so forth. Now, in most cases, those are findings that you came up with during your examination. So what we need to think is, what is the cause of those findings, or what is the cause of those impairments? Okay, so we're really looking for the causative tissue or factor to make them tissue-specific impairments. We'll look at the stage of healing, and in this course we will call that the stage of condition. We will look at tissue reactivity, or how reactive the tissue is to stress placed on it. Subject reactivity, or really when we look through the viewpoint of the patient's eyes, how limited are they? How functionally limited are they? And then their functional goals as well. Okay, so really, what do they want to get back to? What are their expectations? What do they want to get out of therapy as an individual? So let's start with stage of condition, or also known as stage of healing, but we just refer to it as stage of condition. There are a few we're going to discuss. There is immediate. This is the one we probably deal with the least. This is usually when you're there when the incident occurs, or you're there in the first few minutes afterwards. This will probably happen more in your social life than it will in your therapy career, unless you actively work with people in the line of fire for potential injury in the moment, such as athletes. So this is when we're thinking about first aid, right? The next, and this is a continuum, is acute. With an acute stage condition, this condition is worsening, and your goal is to limit the worsening. The time frame tends to be shorter, but not always. All right, but you're really talking to the patient, asking them how they feel, seeing if they have signs of inflammation, all that good stuff. Does it seem like this condition is worsening, or does it seem like it's getting better? Does it seem like it's staying the same? And if it seems like it's worsening, it's most likely acute. Subacute is really commencing to improve. All right, so they feel like they're getting better. They may still have some signs of inflammation. They don't have to, but they may. But the signs of inflammation are usually steady or getting better, and in most cases the signs of inflammation are improving. Give you an example. They still have swelling, like they sprain their ankle and they still have swelling, but they have way less swelling than they did 3 or 4 days ago, and overall they have less pain and they feel like they're doing better. Well, they still have signs of inflammation, but they're overall improving, so they're subacute. Now, subacute is a fragile stage of condition. So with subacute, when you're determining the interventions that you want to give that patient and what you want to do with them in the clinic and have them do at home, you have to remember that you could easily flare them up and set them backwards. If you don't respect normal tissue healing and you're too aggressive, you could put them in the acute stage of condition. Okay, moving on, let's talk about the other few remaining. The next one after subacute is settled, and settled is when they're initially stabilized. So they really feel like usually they're feeling the same overall now, and of course they could still have signs of inflammation, but they're way less likely to have true cardinal signs of inflammation and more likely to have something just like swelling maybe. Corrective treatments you can be more aggressive with now. All right, you don't have to so much worry about flaring them up because there's been enough time and enough healing has occurred at the tissue level that they're stabilized. So they'll take these corrective treatments where you can be more aggressive. All right, and chronic. Chronic is the last one, and that is a vague guideline there, but usually at about 15 weeks, which is just over 3.5 months, the patient has had all their primary healing occur. They're more likely to get pain behaviors like psychosocial implications. So when somebody has maybe a chronic injury, they've had it long enough, they may even feel like they're suffering. And when a patient feels like that, they can become despondent, they can report that they're aggravated, they're not improving, they can break down and cry on you and become emotional. So any really large-scale emotional component for a problem that's been there a while makes you think this is more likely to be a chronic stage of condition. All right, now it is very difficult to tell the difference between settled and chronic, so I really advocate you look at all the information you're given and you make a decision based on a 2-column decision chart. So anytime you're approaching a patient case or patient, you're trying to decide what stage of condition they're in, I think you should look at all the variables. So the variables we've discussed so far have been how much pain they're in or their pain level. Overall, if the patient feels like they're getting better, worse, or staying the same. The time frame, the time that's occurred and the tissue we're talking about, right? Or tissues, because we only choose one stage of condition overall for the patient. But if there's only one tissue, that makes it a little bit easier. If there's any psychosocial implications to this, like is the patient despondent? Are they overly emotional? Is there a major psychosocial component to this? And signs of inflammation is another key factor that we look at. Do they actively have any signs of inflammation or not? And remember that. We'll discuss this more in class, especially if anybody would like further discussion on it. But swelling is not always a means to assume that there's inflammation. All right, but if there is active inflammation of the body, there is always swelling, even if you can't clinically pick it up. And I'm sure you're familiar with all the metabolites and the cellular structures in the physiological model of the human body that are activated in response during an inflammatory reaction. So you must have at the very least some increase in fluid and interstitial fluids to move those factors through the tissue. So if there's inflammation, like it's red and it's warm, there's swelling even if you can't pick it up. It's just probably on a lower level. But if it is a just swelling and that's all you pick up, it doesn't mean that it's inflamed. And I think that we can all think of a chronic condition that we may have had. Maybe you have a chronic ankle sprain, and when you do a certain amount of load on it, like maybe when you run over the bridge, the 312 bridge, you'll notice some swelling in it. But if you just run for a mile on flat land, it doesn't really swell up. You don't notice anything. So when you run over the bridge, does your ankle feel hot, and do you see redness to it, and do you feel warmth, or do you just get some swelling the next day or the same day? So it doesn't always mean inflammation, but inflammation always means swelling. Okay, so back to stage of condition. These are the two hardest to differentiate between, and I've had students ask, well, in other courses we don't have that settled stage of condition. So why do you guys do that? Is it to be tricky? It's really to use more critical thinking, to make you analyze the subject and scrutinize them a little more, so you don't just lump them into three more broad categories. And the only one that's not up there is one that we'll probably use later in the term, and that is a chronic condition with an acute flare-up. And that's a situation such as running over the bridge that I gave, but let's say that you had this chronic ankle instability, it's this chronic problem, it's been staying the same, and you should wear your brace, but let's say you go and run the 312 bridge, you do not wear your brace, and your ankle becomes red, swollen, warm, and very painful. That is an acute flare-up of a chronic condition. So that's the only other variable. All right, stage of condition now is done. We're going to talk about tissue reactivity. So reactivity of the tissue, and I cannot tell you how many times students unfortunately get confused between the stage of condition, tissue reactivity, and subject reactivity. So be very clear about what you're talking about. All right, so tissue reactivity is first on these tissue versus subject reactivities. We have three types. These are directly out of your E1 manual, and we'll cover them as well here. And by the way, if you're not using your E1 manual to help you study, most of this information comes directly from that. And so it is a very valuable resource. All right, high tissue reactivity means there is pain before tissue resistance. All right, so when I stress the tissue, there's pain before I feel resistance or the restriction. I'll give you an example. Example given is for treatment. So they're like, well, if they have pain before you feel a resistance, then you could treat using lower level oscillations. So you're trying to gate their pain, more or less, and get a psychological effect, but not really a manual mechanical effect, because they wouldn't be able to tolerate it right off the bat. All right, moderate tissue reactivity means there's pain with tissue resistance, or when you hit the restriction. So that's somebody where in the real world, when you're treating them, you might want to oscillate in the lower grades, and then you will go and do a stretch, like a static end range stretch, and then because that may cause some more pain again because you're at that restriction, then you back off, and then you do lower level oscillations again. So you have this complete corrective intervention. Low tissue reactivity means there's no pain when you stress that tissue. There's no pain. Patient does not report any pain. They don't guard. They don't stop you. So that's somebody you can just go in and just stretch them. All right, here's my example for this that I think will help. Let's say the tissue that you're trying to determine the tissue reactivity of is the patient's hamstrings. So you perform a straight leg raise because you want to maximally passively stress that tissue to see how reactive it is. So you do an MLT, which is your straight leg raise for the hamstrings. As you're bringing their leg up, before you feel any resistance, and I think we can all identify about how you feel resistance through the patient's leg when you're stretching their hamstrings. So at that point, they stop you, they guard, or they have pain. They say, ow, stop. They make a funny face, shows they're in pain, whatever. You're like, well, I didn't feel a resistance. Now, muscle guarding abnormally in the range is not a true resistance, right? That's a patient-controlled resistance, not a passive tissue. So we throw that under high reactivity as well. If they guard, or if you just have them stop you and you don't feel anything. It's like this MTN feel. They just say ow and you stop. You never felt any resistance. That's high. Moderate tissue reactivity is when you feel pain at the resistance. So you're going up, and as you start to feel their hamstrings pushing back against you with the straight leg raise, you feel that tissue resisting you. They say, ow, that hurts. That's moderate. That is moderate. And then low means you can do like a normal straight leg raise and there's no indication of pain. So that is the basis of how you're going to gauge tissue. All right, now we need to talk about what step to use, right? So it's really something that we want to do. Us as the therapist, we want to be the one stressing the tissue. I trust what I feel. I can't 100% trust when a patient is in control of this test I'm doing. They may compensate. They may just not report pain even though they have it, right? So I want to be in control and be very clear with my instructions to the patient. So it's got to be something that you as a therapist do to the patient. So when you're trying to determine the tissue reactivity of a tissue-specific impairment, you need to first think of what kind of tissue is this? Is this a tendon? Is this a bursa? Or is this a joint capsule? If it's a tendon, then I need to think, all right, what would really stress a tendon the most passively? And what should pop in your head right now is an MLT. That would be my first option. If it was a bursa, I would think, all right, what would probably most likely passively stress a bursa that I'm in control doing? It's usually going to be palpation for tenderness. Not always, but usually. For a joint capsule, now I'm thinking passive range of motion accessory. So let's talk about some tissue-specific impairments. So if the tissue we're dealing with on your left, on the left side is the tissue, on the right side are the potential impairments, and then we'll put them together and make a tissue-specific impairment. So the tissue is the joint capsule. Maybe it's the MCP joint capsule. Maybe it's the talocrural joint capsule, but it's a joint capsule. Some potential impairments, and by no means is this an all-inclusive list, would include a tight capsule, a tight joint capsule, an adhesion, which is scar tissue formation, usually somewhere within the capsule, either layer of the capsule, and so you feel that limitation in one direction. Could be a laxity where the tight joint capsule, the capsule is loose and it's excessively loose, and we can have those in one direction, in multiple directions, or in all directions. Or it could be effusion. Remember that swelling is either effusion or edema depending on its location. So if the swelling is within the capsule, then it's effusion. Okay, so let's go back. Let's make this a tissue-specific impairment. So tissue-specific impairment would be right MCP joint tight capsule, or right MCP tight joint capsule. Either way would be fine. All right, so that's our TSI, or tissue-specific impairment. Now, what would be the best step for getting tissue reactivity? Well, what would stress the joint capsule the most? Well, my first choice is usually going to be passive range of motion, but sometimes there will be a special test that fits really well in that category. Really well. I'll give you an example. Let's say we're looking at the ATFL of the ankle, and so the ATFL really binds with the capsule, very much so. And so let's say they have this rupture of the ATFL, and they also have a talocrural joint laxity in the anterior direction. So you could argue that passive range of motion accessory would be the first thing I would look at. But you also may be able to argue, if you had data for the special test of an anterior drawer test of the ankle, you could also argue that that would test that uniaxial laxity, or that laxity in just the anterior direction of the talocrural joint. It would be hard. It would be a wash, so I would accept either one in that case. But generally speaking, it's going to be passive range of motion accessory. We're moving on now, and since we mentioned capsule, let's talk about a common condition, and that is a tight joint capsule. And a tight joint capsule presents with a capsular pattern. So when you're looking at a tight joint capsule and a capsular pattern, you always have 5 findings that tell you a capsular pattern is present. And these are the steps that give you that finding, okay? So the findings are, the big blue arrow means decreased. So all these are decreased or less than normal. So you would say decreased active range of motion, decreased passive range of motion, classical, so on and so forth, all the way down. Okay. Remember that. It's decreased. Okay, so Decreased active range of motion is in a specific pattern, so you would write that pattern. Okay, so we've been discussing the MCP joint, so let's stay consistent with that. So we have decreased joint active range of motion, flexion is limited greater than extension, right? Or decreased joint active range of motion, flexion greater than extension. And then, and some of this isn't going to make a lot of sense right now, but keep referring back to this PowerPoint and this lecture, and it'll make sense because we're going to hit this time and time again throughout the term. Passive range of motion classical is going to follow that as far as the quantity is concerned. So it would also be flexion greater than extension limited. And then the quality is your end feel. When you're thinking about quality, think it means the quality of the resistance. So the quality of the resistance is your end feel, and that quality is always going to be tight joint capsule. Okay, tight capsule end feel. And those end feels are listed in your E1 manual, and you must know those. When we go to accessory now, as far as quantity is concerned, we have to match the accessory motion with their component motions. So for flexion, you get an anterior glide of the proximal phalanx. That would be limited greater than a posterior glide, which is the component motion for MCP extension. So we still have that concept of flexion limited greater than extension. We just have to speak in accessory terms now. So the accessory terms are anterior glide limited greater than posterior glide. But the quality is, again, the same thing as before. It's your end feel. So it's going to be tight joint capsule again. Let's move on. Okay, let's continue talking about TSIs. So let's talk about a ligament. Ligament, again, is a tissue, and impairments that can occur would be something like laxity or maybe an adhesion of the ligament. So a tissue-specific impairment, let's say, of laxity would be like a tear. So a TSI for this could be a ATFL grade 2 tear. That would be a tissue-specific impairment. Or an adhesion of the patient's right MCL. So that would be an adhesion of the MCL, which would be a tissue-specific impairment, right? So we take the ligament, we take what's wrong with it, or the impairment, we add a little more specificity to it by naming what specific ligament, and we have a TSI. All right, so what would best stress a ligament? Well, generally speaking, it may be something like accessory, could be a special test, or even palpation for tenderness. It really depends on the ligament. Give an example. All right, let's go back to the MCL at the knee. The special test for MCL at the knee is doing a valgus stress test at both 0 and 30 degrees. Now, when we do this, we're performing really a special test. Passive range of motion accessory would not be the primary choice. It would be the special test of a valgus stress test. That would be my first choice. My second choice would be palpation for tenderness. And my third choice would be passive range of motion accessory, right? But let's switch gears for a second. And what if it was the ATFL of the ankle? Well, now I could use either the passive range of motion accessory or the special test, because I could use an anterior drawer special test, or I could say an anterior glide or a PA glide of the talus. So those would both be acceptable, but in that case as well, I would rather use the special test of the anterior drawer test. What about tendon? Tendon, these are what you generally see. A partial tear, a complete tear, a tendinitis, or tendinosis. All right, these are your types of tendinopathy. An itis means an inflamed tendon. This is a lot more rare. And an osis means a pathologically degenerative tendon. Oh, so let's make a TSI out of one of those. How about a right ECRL tendinosis? Okay, so we named the tendon of which that muscle belongs, and we named what was wrong with it, the impairment of tendinosis. So we made a TSI. Now, what would best stress that? Well, tendon is going to fit the same as muscle in that we have MLT is most likely going to be our first choice. passive range of motion classical. If that stresses it and we don't have MLT, either we weren't given that data or we are not able to actually perform the test due to our findings in subsequent exams such as MSTT. And if I didn't have those, then I would look at palpation for tenderness. So what we've done is every time we look for the tissue reactivity, we look for the test that best passively stresses the tissue, which fits the definition of tissue reactivity. The best step to passively stress the tissue. And if we don't have the best step, we look for the next best step and then the one following that, right? So our clinical rationale is based on the definition of tissue reactivity. All right, muscle. For muscle, we have a potential impairments, partial tear, complete tear. Muscle could be tight or short, and muscles could be weak. We're very familiar with that. What would best stress that? Well, look, this is a carbon copy of tendon, right? So the same step of MLT would be my first choice. Passive range of motion classical, that would stress it, or you can think of it being passive range of motion classical that best simulates the MLT. That would work. So let's think of an example. Let's say you had a weak long head of the biceps, right? We don't really differentiate that with MMT, so we could just say a weak biceps muscle. So with our weak biceps, we look at MLT. There's no MLT data. Let's say they had a reason where we omitted MLT. So now we look at passive range of motion classical. If all I had was elbow flexion, that wouldn't work, right? I would have to have elbow extension at a minimum to use passive range of motion classical. It'd be nice if I had elbow extension and also shoulder extension, right? And then when we get into the pronation, supination, that of course becomes, an MLT. So let's continue on. Now we're talking about fluid, okay? 3 places fluid is. So we have a bursa, which is a fluid-filled sac, which is usually meant to prevent forces from being transmitted from one tissue to another or give yourself some cushion. We have edema and we have effusion. So edema is fluid outside of the joint and effusion is fluid inside of the joint. Well, let's give a TSI of a bursa issue. How about a greater trochanteric bursitis, right? Or if it was edema, we need to name the specific location of that edema. So if you're looking at a patient and you think their calf looks swollen, and of course you're, let's say, 8 centimeters distal to the tibiofemoral joint line, then you have edema 8 centimeters distal to tibiofemoral joint line. So you name the specific location. If you just say the patient has calf edema, then you have the tissue and you have the impairment, but you're not specific enough. You want all 3 parts. For effusion, you name the joint. So if you have swelling inside the knee capsule, that's tibiofemoral joint swelling or patellofemoral joint swelling, or both, depending on what your findings were. How do we stress those? Well, if it's a bursa or edema, you generally get on that specific location and you compress that tissue via palpation for tenderness, and then you would rate the reactivity based on the depth. And we will go over a case example using this. If it is swelling within the joint or effusion, you have to go back and think, what is the best step to stress the joint capsule? And that step would also be the best step to stress anything within the joint capsule, like effusion in this case. So effusion be your choice there. So when we are determining the tissue reactivity, we have to look at certain steps of our clinical exam. So of our 18 steps, we want to determine which one is best for rating how reactive that tissue is to maximal stress. So keep in mind, you have already done all of your 18 steps when you're trying to determine tissue reactivity. This isn't something you need to necessarily do during the examination. This is more of a reflective process that you do during the evaluation. So first you say, all right, I have this tissue-specific impairment. I need to think, what type of tissue am I dealing with? Is this muscle or tendon? Is this ligament? Is this a pocket of fluid, extra-articular or intra-articular? So what type of tissue is it? And then when I look at my 18 steps, what would passively stress that tissue the most. All right, and then once you've determined that step, you look at the step that would stress it the most passively, and then you look for symptoms. All right, were there pain and or symptoms during this step or not? And then if there was pain / symptoms, when did they occur? When did I actually provoke those? So let's take a look at this. We're looking reflectively back at our examination findings, and we find that we have a tight biceps based on our MLT. So our tissue-specific impairment is a tight biceps muscle. What step did I find it? Well, of course, the best step for finding the tightness of muscles, for assessing the length of muscles, is your muscle length test, or your MLT. Now, in this case, when I did the MLT, if you look at your very first line, you'll see that there was pain at the end of the range of motion when I was performing it. And again, I want you to stay away from using range of motion, so I also wrote tissue resistance. How would you know you were done with the MLT? Because you would feel the biceps resist you at a certain point once you ran out of length. That you have to get to the end of range in order to do a length assessment to determine it's tight to begin with. So you get pain at resistance, basically. You were able to attain resistance, but that hurts. So I use the MLT to actually find it, or detect this issue. Now, does this stress the tissue the most? Well, what tissue is it? It is a muscle. Would an MLT passively stress that tissue the most? Yes, of course it would. So in this case, the MLT is my step I would use. Is there pain? Yeah, there's pain with it. There's pain when I was able to get resistance. Therefore, the reactivity of this tissue is moderate. Pain with ability to reach resistance, or sometimes we'll shorthandedly say pain at resistance. Here's another example. Now we have a biceps again, but this time the biceps muscle is weak. So we have a 3+ out of 5 MMT grade. So MMT is the best step for determining the strength of a tissue. My tissue-specific impairment that I determined from the MMT was very simply a weak biceps muscle. So what step was it that I found it was weak? Well, it's the MMT. I know this is redundant, but stick with me. Does that step, an MMT, passively stress that tissue the most? You should have an answer in your head right now. No, it does not. Why? Well, why isn't that the step you pick? Well, always go back to your definition of tissue reactivity. All right, it's the response of the tissue to maximal passive stress. That's where we look first. MMT is an active step, therefore we would not look at that. So what would we look at? Well, of course, we would look at the same step. It's still a muscle tissue. That's the type of tissue we're dealing with. And in our previous example, we saw that that was the MLT would be the best step to stress the tissue passively. So I can't even use this MMT data to determine tissue reactivity. I used it to detect this problem, but I can't use it for tissue reactivity. All right, so if my MLT, when I look back at that, it's normal length and pain at tissue resistance, then this is also moderate. So if there's no pain when I reach stress of that tissue, I maximally stress it, then it's low. If there's pain when I stress the tissue, or pain at tissue restriction, then it's moderate. And if they can't tolerate full stressing of the tissue, like they report pain before the restriction or there's significant guarding, then it's high. I'd say that we're talking about subject reactivity. This is an important conceptual concept here. Subject reactivity is seeing through the eyes of the subject, or in this case, the patient. All right, so you got to put yourself in their shoes and truly empathize with the patient. So this scale is slightly different because remember, it's not just your viewpoint, it's their viewpoint. So it's what they report to you during the history. So if it's high, they cannot carry out their normal functional activity because of their complaints. They can't carry it out. If it's moderate, they can finish it. The full activity they can finish, but it hurts them during the activity. Are they going to have pain afterwards? More than likely. But the main component is they finish their activity and it pains them or they have symptoms during. Low reactivity means they can carry out their functional activity and it does not hurt them during. No pain. Low reactivity is like normal. Whether it's subject or tissue reactivity, low is normal. Low is you guys sitting out there thinking about stressing a tissue in which you do not have pathology. You know, if we're talking about subject reactivity and you like to run and you're having no issues with your running, of course, you can go run and your normal run's 3 miles. You run 3 miles, doesn't hurt you, good. That's normal. Normal is low. All right, so no pain during, you can fully finish the activity. If it hurts you afterwards and only afterwards, it's still low. It doesn't have to hurt afterwards, but if it does, still low. Let's move on. How do you determine subject reactivity? Subject reactivity is really found in the history, primarily the history. And it's from what the patient reports they can or cannot do. Now, we may incorporate some functional scales in this course as we go. We may use that as well to put more of an objective number on their subject reactivity. But for right now, we're going to leave it at this point in the term. So what the patient says they can or cannot do, and you want to look at all the functions of the patient. So maybe you have someone who works as a administrative assistant, but their favorite hobby is bowling in the evening. Well, the administrative assistant can work the full day, they're fine, all right, and they have a little bit of discomfort after they get home from work. So they have no pain during the day, during their functional activity of working. Well, then it's low. That's their subject reactivity. But what if they say, I've had to stop going bowling, it hurts too bad, I can't bowl a complete game. Well, then it's still low for work as an administrative assistant, but the subject reactivity for bowling is now high. So they have two separate subject reactivities. You do not combine the two. All right, when we're talking about treatment interventions, we have 4 categories of treatment intervention. We have palliative, preparatory, corrective, and supportive. The palliative treatment is where we treat the pain. It's where we treat pain. So if the patient has significant amount of pain, we treat it here under palliative. It's only during pain. And maybe as simple as resting the tissue to get it calmed down, heat, ice, modalities, massage, that sort of thing. All right, the preparatory is preparing to correct the problem. All right, so you're making your corrective treatment, which is what you'll do next, better. You see some examples there. All right, the corrective treatment is what you're going to do to correct or fix the problem as is appropriate based on their stage of condition, their tissue reactivity, and their subject reactivity. And then supportive treatments are supportive to your corrective. So your corrective is what you do in the clinic, and then your supportive treatment is what you're going to do at home to support the gains you made or the changes you made or your goal with your corrective intervention. So supportive does the corrective. Now, the caveat on the supportive is it needs to be done elsewhere in the treatment. Okay? Because supportive you're going to think is what they do at home. That's really your home program. All right? So you can't just send them home with a new exercise or a stretch or posture if you haven't worked on it somewhere else here. Now, it may take you to finish your corrective treatment before they would be able to do that activity, like before they would be able to get in the full normal posture if you're giving them postural Therex for their supportive treatment. That's fine. You just put it at the very end of corrective. When you write things down under a section, that's the order in which you're doing them in the clinic. All right, so I'll give you an example. Let's say under corrective, you want to do a static end range hold to make a change, make a mechanical effect to the joint. And then after that, you want to have the patient, this is for, let's say, the glenohumeral joint, then you want to have the patient elevate their arm for a supportive active motion. Well, in that case, you couldn't have them repetitively elevate their arm to reach a cupboard or to reach a cup out of a cupboard. You couldn't have them do that until you got the mechanical effects. So you would have the corrective intervention of stretching that adhesion or that tight joint capsule or whatever you're trying to do first, and the second thing would be that active motion to support it That's what you would have under corrective. All right. And then under supportive, you would just again write that reaching the cup out of the cupboard. All right. So it's a little bit repetitive at times, but that's okay. It clearly demonstrates what you are trying to do. And there's an important caveat we're going to hit on when we get to the cases in a moment. But remember, if you get a mechanical effect during corrective, you must support it. All right. So if you're stretching a muscle under corrective, then you have to have them do stretches at home to maintain those gains. If you're doing a joint mobilization in corrective, they must support that joint mobilization by actively and hopefully functionally moving into the new range that you helped create. All right, when we're talking about treatment interventions, we have 4 categories of treatment intervention. We have palliative, preparatory, corrective, and supportive. The palliative treatment is where we treat the pain. It's where we treat pain. So if the patient has significant amount of pain, we treat it here under palliative. It's only during pain. It may be as simple as resting the tissue to get it calmed down, heat, ice, modalities, massage, that sort of thing. All right. The preparatory is preparing to correct the problem. All right. So you're making your corrective treatment, which is what you'll do next, better. You see some examples there. All right. The corrective treatment is what you're going to do to correct or fix the problem as is appropriate based on their stage of condition, their tissue reactivity, and their subject reactivity. And then supportive treatments are supportive to your corrective. So your corrective is what you do in the clinic, and then your supportive treatment is what you're going to do at home to support the gains you made or the changes you made or your goal with your corrective intervention. So supportive does the corrective. Now, the caveat on the supportive is it needs to be done elsewhere in the treatment. Okay? Because supportive you're going to think is what they do at home. That's really your home program. All right? So you can't just send them home with a new exercise or a stretch or posture if you haven't worked on it somewhere else here. Now, it may take you to finish your corrective treatment before they would be able to do that activity, like before they would be able to get in the full normal posture if you're giving them postural Therex for their supportive treatment. That's fine. You just put it at the very end of corrective. When you write things down under a section, that's the order in which you're doing them in the clinic. All right, so I'll give you an example. Let's say under corrective you want to do a static end range hold to make a change, make a mechanical effect to the joint, and then after that you want to have the patient, this is for, let's say, the glenohumeral joint, then you want to have the patient elevate their arm for a supportive active motion. Well, in that case, you couldn't have them repetitively elevate their arm to reach a cupboard or to reach a cup out of a cupboard. You couldn't have them do that until you got the mechanical effects. So you would have the corrective intervention of stretching that adhesion or that tight joint capsule or whatever you're trying to do first, and the second thing would be that active motion to support it. That's what you would have under corrective. All right, and then under supportive you would just again write that reaching the cup out of the cupboard. All right, so it's a little bit repetitive at times, but that's okay. It clearly demonstrates what you are trying to do. And there's an important caveat we're going to hit on when we get to the cases in a moment. But remember, if you get a mechanical effect during corrective, you must support it. All right, so if you're stretching a muscle under corrective, then you have to have them do stretches at home to maintain those gains. If you're doing a joint mobilization in corrective, they must support that joint mobilization by actively and hopefully functionally moving into the new range that you helped create. Okay, application 1 is where we're going to begin going over this in class. This stimulates a lot of discussion. So that's it, and we will continue on this in class. Please email me if you have any questions. Thank you. Okay, application 1 is where we're going to begin going over this in class. This stimulates a lot of discussion. So that's it, and we will continue on this in class. Please email me if you have any questions. Thank you.